bone health, and very happy to introduce all of you to Dr. Frederick Singer. He's the director of the Endocrine and Bone Disease Program at John Wayne Cancer Institute right here in Santa Monica. He specializes in metabolic bone disease and has long-term experience in osteoporosis, and which develops in cancer patients and individuals with bone metastases. So he is here to talk about, frankly speaking, about cancer bone health. Please welcome Dr. Singer.
So that's me. Okay, so what are we talking about? Bone health? How does cancer directly affect and treatment particularly badly affect your bones? What in the world is osteoporosis? What's bone metastasis? And what can you do to stay as healthy as possible with respect to your skeleton? So even if you don't have cancer, there's an enormous number of people, mainly women, but some men, who have osteoporosis as they get older. So it's a concern for all adults, whether or not you've had cancer. Now you need to eat healthy, you need to keep strong muscles, particularly in your legs, so you don't fall and break your hip. And it's really important to think about your bones as you get older, and even when you're younger, because some people getting drugs like steroids can develop osteoporosis at age 20 or 30 early on. So what is bone health? The bones are alive. They seem to be very stiff and strong, but they are living. They're hard, and they're mostly made up of a protein called collagen, similar to what's on your skin. That's collagen, and then calcium and other minerals. The bones have two layers. The outer layer is the dense layer, the cortical bone. The inner layer, called trabecular bone, it's a spongy structure where there's more bone cells. So what's the point of having bones? Well, I wouldn't be standing here, for one thing, if I didn't have bones. So they help protect your body, your brain, the skull, your heart, and other organs from injury. They obviously support the body, and you're allowed to move around, walk, run, jump. They store minerals, calcium and phosphorus. That helps keep them strong. And very importantly, the bone marrow lives within the bone. So red cells, white cells, platelets, all these things are important for healthy life. And so that takes place within the trabecular, the inside part of the bone. There's some fat storage, which in bone marrow called yellow bone marrow, which can be released to give you energy. By the way, you can interrupt me at any time if you have a question. It doesn't bother me. So just raise your hand. Yes?
If somebody is osteoporosis completely with the injection that they call Prolia, you can get back the...
So the question is the treatment of osteoporosis with Prolia. We're going to cover that. It's a little early for that, but we'll cover that. So bone remodeling is an important physiology of bone. So bone is alive, so there's processes where you form bone cells making bone, and bone cells removing it. It goes on throughout life. So it says if you remodel your kitchen, you can put down a new floor, you have to take out the old tiles and put down new ones. It's an interesting way to think about bone remodeling. So inside the bone, there's special cells, some called osteoclasts, which remove the old bone, and then the other cells, osteoblasts. The only difference is a C and a B, and that forms new bone. So there's various illnesses where one cell or the other is affected by drugs or other illnesses. So what happens is when you're born, you're pretty small. You're down there, and then if you're fortunate, you grow. Over time, you kind of reach maximum bone roughly around 25 years of age, plus or minus. You know, nothing, no harm in it, but women have smaller bones than men. No big problem. But it does lead to a problem in menopause much later. If you start with a normal amount of, but less bone than a male, it explains why osteoporosis is much more common in women. Maybe 20% or 30% of osteoporosis are in men, so it's not zero. But women have less bone, and then they have this unfortunate episode at age 50 where their ovaries say, we've had enough. And that's a huge factor in women. When the estrogen level in blood drops, you start losing bone. The bone cells that chew up bone are much happier. They're not suppressed by estrogen. Males may lose bone slowly with age, but I'm not clear that there's a real male menopause. I think there's an argument about the male hormone testosterone in elderly males. Some men have low testosterone, but that's a disease mostly, not just age. So, as I showed you, bone density changes over the whole lifetime. You're building bone at least up until age 25, and then the more bone that you have, the better you're starting off with. And you're 25 to 30, you have maximum bone, and then bone density decreases in women almost primarily by decreased estrogen. In men and women, calcium, vitamin D, exercise are helpful in slowing down the decrease, but they don't generally take the place of estrogen, sadly. In very elderly women, I do find that calcium and vitamin D may prevent bone loss, but in most women, that's not enough. And so women come in with a bone density, osteoporosis, and they say, I don't understand what's going on. I take a lot of calcium, vitamin D, and I'm exercising. Why are my bones not good? They aren't taking estrogen or something else to protect their bones. And so that's a common, people think that just doing calcium, vitamin D, and exercise is enough. Unfortunately, in most women, it's not. And then, of course, if you smoke heavily and are inebriated frequently, those are devastating for the bone. So not to say you can't smoke one cigarette a day, that's fine if that thrills you, or take a drink of wine once a day, that's okay. It's overuse is unhealthy. So until about 25 years ago or so, all we had were x-rays. You'd take an x-ray of somebody and say, looks like there's not enough bone. But that was very vague. So bone density testing, at least 25 years ago, became a very important way to figure out what's going on with bone. There's several types, but the most common type is called DEXA, or dual energy X-ray absorptiometry. Fancy words. The DEXA measures the level of mineral in the bones. It's not dangerous. It's very low dose X-ray. It's much less X-ray than taking a chest X-ray, for instance. And usually the spine, the lower spine, and the hip are measured, sometimes the wrist. But the most important evidence comes from the lumbar spine and the hip. You can often get a report from the doctor or from the radiologist, and the key thing is a T-score. That's a measurement of how your bone density compares to what you'd expect to see in someone that's 25 years old, maximum bone. So a T-score of 0 is average, -1 is not bad, plus is good. So we're looking at these T-scores, and if you're between -1 and -2.5, that's considered lower bone density than average, a young average, and they call that osteopenia, not osteoporosis. And if the T-score is -2.5 or worse, that's called osteoporosis. It's not entirely helpful. If I told you that more fractures occur in the United States in people with osteopenia than because more people have osteopenia, there's more fractures in osteopenia, but you're much more likely to have a fracture if you have osteoporosis. So when you have, and also the range here, if you're -1 or -1.1, that's nothing. If you're -2.4, that's about the same as osteoporosis. So you have to, it's a little tricky because there's such a wide range of this osteopenia. I don't think this was well planned, you know, the terminology was not well planned. So basically, if you're close to -2.5, that's fairly threatening. But people have low bone density and never have a fracture because they don't fall on their hip, they don't lift 150 pounds, they don't do wild twisting of their back. So, you know, fractures can occur spontaneously in people that have the lowest bone density, -4 or -5, but fractures are more likely from 90% of hip fractures come after a fall. So you can prevent 90% of hip fractures by having strong muscles, hopefully not being wobbly, and avoiding the streets of Los Angeles with all the tree roots. So you can avoid 90% reduction of hip fractures by just not falling. Hard to, you know, carry out after a while, but that's a goal, no falls. So what is osteoporosis? Well, it's a medical problem. You want to call it a disease, it's okay, that fits in the category. So women and men with osteoporosis have become quite thin and weak and are more likely to break. Osteoporosis in Greek, porous bone. Something that is porous has small spaces or holes, and this is an excellent picture. This is normal. This is the internal bone, the trabecular bone. You see holes, but you see a lot of collagen. That's mainly collagen there. And here's osteoporosis, big holes. So this is stronger than that, obviously. The bone density machine, actually there's newer tests that give some images, something like this, but the standard machine is just measuring the density of this. It's not giving you a picture of this, but it's very useful, you know, in deciding, is there a problem? Only 54 million people in the United States have osteoporosis.
Almost everybody.
Only. Now the sad part is, much of that is preventable, believe it or not. But it's preventable by paying attention when you're younger than 50. And there's roughly 2 million broken bones a year. And that hurts each time. Although it's true that in the spine, some people have a very slow compression of vertebrae and go like this, and they may not have an acute pain. So it's tricky. You can have compression of a vertebrae gradually over many years where you don't have a sudden compression. But the ones we're concerned about the most are when the collapse, it hurts terribly, the muscles are in spasm, you lose height permanently, so it's no fun. Okay, getting to the big subject of cancer. So some cancer patients already have osteoporosis. I don't know what percentage, probably not a huge percent, but a certain percentage. And then, because they have cancer, they receive cancer treatment other than surgery now. Surgery is not harmful necessarily to the skeleton, but cancer treatments other than surgery can increase their risk of developing osteoporosis or reducing their bone density. A small number of cancers can start in the bone. They're called sarcomas or osteosarcoma. More commonly, certain cancers, breast cancer, lung cancer, and some others, if they're not cured, by the surgery, or if the patient hasn't even been treated. I worked at LA County Hospital for 15 years in the past, and I saw patients that I rarely see in West Los Angeles. There they came in with bad cancer and their bones were filled with cancer. So it was a wonderful opportunity to study how to treat that, but it was a horrible thing to see. All these poor people that didn't have medical care until they're half dead. So the cancers can spread to the bone. Now in West Los Angeles at St. John's, there are patients like that, but they're a tiny percentage of LA County Hospital population. So
multiple myeloma deteriorate the bone similar to osteoporosis?
yeah, the question is, does multiple myeloma deteriorate the bones? Multiple myeloma, which is in the marrow, produces chemical factors which make bone loss happen.
Does it look like
Without treatment, just multiple myeloma. And it can make the calcium in the blood by removing the calcium from the bone, it goes up in the blood. You had another question?
Does the bone look like it does under osteo?
Yeah, the bone density,
Similar.
is it the same in multiple myeloma? If it's active and cause bone loss, yeah, you have a low bone density. But you need a bone marrow examination to diagnose it. So that's not metastasis, but that's starting in the bone.
Is bone pain from cancer constant, or can it be intermittent?
Is bone pain from cancer constant or intermittent? In my experience, it's more constant in general. But I suppose it can be sometimes intermittent, but it doesn't just wax and wane. It often persists. So if you happen to be treated, first of all, for osteoporosis, and then you get a cancer, well, in the history taken by the oncologist, you tell the doctor, I have osteoporosis, I'm doing this or that, taking this medicine or not. So you got to make sure that they know you already have osteoporosis. And then make sure your cancer doctors know what medication you might be taking for that. And then you tell the doctor that's treating you for osteoporosis, I have cancer. So that gives you some safety in what's done to you and what happens to you. They all have to know, what's going on. The treatment of osteoporosis possibly wouldn't change necessarily, but it depends on the individual circumstances. But you need, every doctor that's taking care of you needs to know everything. So the sad part is that many cancer treatments can affect bone health. And generally, but not always, it's due to a loss of bone. The bone cells are chewing up the bone. Sometimes it's the bone cells that are making bone that are affected, that are reduced. So it could be both. But it's clear that cancer therapy can produce a more rapid and severe bone loss than just postmenopausal bone loss, whether it's in men or women. you know, we have been focused more on women, but men, the main problem in men with prostate cancer, one of the treatments is to wipe out testosterone because it helps the cancer, you know, live and grow. So when that happens, bone loss can be severe, but preventable, you know, with a medicine. It's absolutely preventable. Earlier than better than later. You don't want to wait until, oh, the bone density's, I'm still alive, but my bone density is going on. No, you can stop the bone loss right away. That's nice. I mean, but somebody has to think of it and do it. So one of the other issues, particularly in breast cancer patients, the treatment causes premature menopause. So estrogen is reduced. Chemotherapy, I hate to use the word poison, but it's trying to poison the cancer, but it poisons the ovaries, and in some men, potentially the testes. So the hormones drop just from chemotherapy. And then you have hormonal therapy for breast cancer. So without having even had chemotherapy, if you have, if you're given these aromatase inhibitors that's inhibiting estrogen to help survival, but the problem is normal women postmenopause have a little bit of estrogen, which goes down to close to nothing with these drugs. So, and then some women have an oophorectomy. So basically, it sounds terrible, but you can take something that prevents bone loss, period. Not estrogen, but something else. So the other things that can be done in cancer patients are stem cell or bone marrow transplants. Frequently you have to take steroids, prednisone. That's poison for bone, high doses. Children that survive childhood cancer are higher risk. And I don't know, if your stomach is removed because of a stomach cancer, you have problems absorbing nutrients, so that's a problem. Fortunately, I don't see that too often, but that could happen. So it's terrible to show you the awful things that can happen to people. Now, occasionally, I haven't seen this very often, occasionally chemotherapy drugs can lower blood calcium levels. That's generally not a big deal. A temporary side effect of some chemotherapy. If you have cancer in the neck, and like the thyroid, and have a total thyroidectomy, if you also remove the parathyroid glands, they're normal, but if they're accidentally removed, you get a low calcium and you have to take medicine the rest of your life to make your calcium normal. So if the parathyroid glands are removed because of surgery, that produces hypoparathyroidism. Means no parathyroid. That's a special thing for thyroid cancer, generally not the other types of cancers. And so chemotherapy, as I said, can affect hormone production and stop the ovaries to function, and so you get premature menopause. Now in a otherwise normal woman at age 40, whose ovaries for some reason stop working, not from chemotherapy, if they get hot flashes and feel terrible, they're given estrogen. But some women don't get hot flashes. But I personally think any premature menopause, particularly at a younger age, should be treated with estrogen at least till 50, because you're going to start losing bone at an early age.
What about a postmenopausal woman who has a hysterectomy? Will she have the same experience? Because the ovaries are removed, but they have stopped functioning earlier because of menopause.
I'm not sure. The question is.
Well, if the ovaries are removed in a postmenopausal woman,
It doesn't make a big
it's not
difference.
going to
Although, you know, there's a tiny bit of estrogen maybe that, no.
There's
removing the ovaries in a postmenopausal woman because you're worried about cancer of the ovary, that's not a big problem. In men, as I said, chemotherapy drugs may cause the testicles to stop functioning and hormone to drop. And bone loss can occur both in men and women if their hormone is low. Now radiation, direct radiation in the skeleton can weaken the bone, but generally you don't get radiation from your whole spine to your legs, so it's usually local. What I've seen is women with cancer of the uterus may get radiation to the pelvis, and so I've seen some pelvic fractures later in those women. So radiation, at least locally, can damage the skeleton.
What about RAI, radioactive iodine?
What about radioactive iodine? Radioactive iodine does not seem to have an effect on bone density. There's some other issues about some other side effects, but not bone density.
If you have radiation to the prostate, does that affect it?
Question is, what about radiation to the prostate? I think it's pretty local. I haven't seen fractures in that area in men after radiation to the prostate. It's possible, I guess, but I think radiation to the prostate is pretty, they can localize it pretty well and hopefully avoid the skeleton.
I got diagnosed with osteopenia in my hip. Could that have been
Say
in my
that.
hip?
What is
Osteopenia?
osteopenia in the hip? No, that's probably not.
Not really.
Having radiation to the prostate, I don't think would cause bone loss in the hip. Only, the pelvis, but I've not really seen a problem. I can't say it won't happen, but it's very unusual.
You mentioned the brain, so the brain is not local, it's here, up here, so
Yeah.
how it affects the rest of the bone?
I said that, I'm not sure what you're asking.
It's written down, radiation to the brain can cause all of this weakness.
No, radiation to the, not to the radiation to the, radiation could cause some bone loss in the skull,
Ah, okay.
but not the,
Not all
well,
of
I
the
mean,
body.
bone tumors, brain tumors are often treated by radiation, but there doesn't seem to be a lot of complications in the skull. But I'm not sure that radiation is good for the rest of your brain.
I'm sure it's not.
Does immunotherapy have any effect on bone?
Good question. Does immunotherapy have any effect on bone? I'm not aware that it has. I mean, immunotherapy, if it includes steroids in some way, yes, but the immune drugs, I don't think have a major effect on bone loss. At least it hasn't been widely reported. Yeah.
I'm wondering, dental implants, does that have something to do with bone loss during the?
Does dental implants have something to do with bone loss? Not really, but it's, ask a dentist, but I haven't seen that problem.
Some people recommend that you have a bone density test if you're contemplating having dental implants.
Well, the bone density, should you have a bone density test if you're gonna have a dental implant, it's not gonna tell you what the density is of your jaw. And I mean, it might be reflecting from some other area, but I haven't seen that recommendation, if you need an implant. Okay, so hormone therapy and bone health. So as I said, many of the hormone therapies that are used to treat breast cancer reduce estrogen. Low levels can result in bone loss, a huge factor. Premenopausal women with breast cancer are sometimes given tamoxifen, an old drug, and that seems to affect estrogen. But in postmenopausal women, it actually has some protection of all things from osteoporosis. but it's not a strong protection, it's some protection. And the hormone therapies used to treat prostate cancer in men lower testosterone, so any male, I don't care what age, that's gonna have prostate therapy with drugs needs to have a bone density test to see where they're starting at. If they have big, strong bones, maybe they don't have to worry for a while, but if they have a somewhat low density, they need to be treated to prevent bone loss. So, you know, estrogen, testosterone is a very important factor in males. Interestingly, in males, it's hard to believe, testosterone, some of it gets converted to the estrogen. Males don't have big breasts in general, but a little bit of estrogen. And an old pal of mine back east did a little experiment on some males who had low testosterone and were losing bone. And for a couple of weeks, he just gave them estrogen, and it stopped the bone loss. So estrogen, the fact that low testosterone in males means they have a low estrogen. If you raise the estrogen, you stop the bone loss, but they also develop breasts. So it's not a treatment, but it explains that both estrogen and testosterone are significant in males. Strange. Steroids, widely used in some kinds of cancer, and steroids can produce bone loss as fast, high doses can produce bone loss as fast as anything. And so high doses of cortisone in 2 or 3 months can increase fracture incidence in certain populations. It's really powerful. So one needs to pay particular attention, and even if you don't have cancer, but you're getting steroids for rheumatoid arthritis or lupus erythematosus, bone loss is very obvious if you don't prevent it.
So if you get steroids and cream on your skin, does that affect
Do steroids and cream on your skin cause a problem? Not proven. You know, I guess it depends what percentage of your body you smear with the steroids. If it's just a little local, it's probably no problem. If you smear your entire body with steroids, I would think it would cause a problem, but I don't know any condition where you're supposed to do that. Okay, we've talked about all the negative things, so what are the positive things about osteoporosis? The good news is almost any type of osteoporosis, first of all, can be prevented if you recognize that it's going to develop if you don't do anything. And then if it's there, you can keep it from getting worse, or in some instances, improve the bone density. So we have a whole family of drugs called bisphosphonates. Started out in 1991 with Fosamax, and then followed by Actonel, Boniva, Reclast. So these are all very effective in stopping the bone cells from chewing up the bone for whatever reason. The side effects are overrated. About 5% of patients, maybe 10 at the most, get heartburn from the oral agents. So this is an intravenous agent, so that's not a problem. The intravenous drug, zoledronic acid or Reclast, in about 30% of people, after one infusion intravenous, you can have like the flu for a few days, but then it goes away. The cost of these varies greatly. Yes.
For how long, if any of these, like abandonate, for example, taken, if they are taken for how long that could cause these side effects of the bone outcome?
Okay, well, we're going to talk about the side effects. So this, how long can you take these drugs safely? Well, they were originally studied for about 3 to 5 years, but then I see patients that have been taking it 10 years, you know, without safety evidence. So there's something called osteonecrosis of the jaw, and it may happen if you have a tooth pulled, particularly, or if you have infections in the mouth. But in patients getting these drugs, 1 out of 10,000 may have this side effect. But in the internet and newspapers, people have been frightened away from using these drugs for no really good reason. When you have osteoporosis and you don't want to take any drug, the likelihood of having a major fracture at some point is very high, and it's 1 out of 10,000 roughly to have a complication. So I think it's bad. Well, somebody called it fake news.
11, Fox 11.
Yeah. So, and then there's the other thing where your bone in the thigh cracks. That's equally rare. So I've been, you know, I actually was doing some of the original studies, you know, before it was approved, before 1991, and how many of these? I don't think I've maybe seen one patient since 1991 with osteonecrosis of the jaw.
Yes, research has shown that taking, I don't know about all the drugs, but Zometa, zoledronic acid, for more than 2 to 5 years can actually have the reverse effect of creating hairline fractures in some of your bones. And so it's advisable in long term to stop it, and the half-life of it is very, my understanding is very long. It actually stays in your body for quite some time even after you stop.
Okay, interesting point that I was going to get to. I don't like to give these drugs more than 5 years in a row. And interestingly, this reclassed or zoledronic acid, it's incredible. One infusion, 15-minute infusion, can stop bone loss for 5 years, at least. So I give it once every 5 years. But it was approved as giving it annually for a number of years. But I never do that.
What was the product or substance?
Reclassed is the trade name, zoledronic acid. It's very effective in preventing bone loss. 1 dose, 5 years.
Is Forteo in that group of corrected cancer?
Oh, Forteo we'll talk about. Forteo is a bone-forming drug. These are all drugs which stop bone loss, not bone-forming.
Is that Zometa?
Yes.
Zometa is a lower dose, 4 milligrams, and reclassed is 5 milligrams, but there's almost no difference in effect. Some of these drugs are used for bone metastases, and they're given every month or 2. So there you might worry a little bit about the jaw, but for osteoporosis, it's really not a significant problem. Bone metastases, that's a different story.
For 1 pill a month, for example, or 500 for how many years can be tolerated?
I would say 5 years, but I never use it because it's not as effective on the hip as the other drugs. I don't use it. But I would say 5 years for the oral agents and then a drug holiday. But you can give a longer holiday with Fosamax because it stays in the bone longer than these other drugs. These wear off in a year or 2. This 5 years of Fosamax, it still can suppress bone 3 or 4 years later in my experience. But a lot of this is not well documented in studies, but I've been doing this a long time.
Okay, over the past years, I've been on, I think it was alendronate, and then it was on abandronate, and then it was switched, even though I'm postmenopausal, to tamoxifen because of some side effects. Tamoxifen caused different side effects, so then I was off for a while. And then I shot Prolia. So now I have a problem with a loose tooth and some problems, and yes, I'm afraid of osteonecrosis of the jaw. So where does all that fit together?
Well, you're afraid of Prolia causing osteonecrosis.
Well,
of the
even
jaw.
the bisphosphonates can do that.
but it's rare.
And if the tooth falls out, do they have to take it out?
Well, if the tooth falls out, there's no problem. It's when they have to put an implant where you.
It's not the extraction itself, because I read it's extraction,
Well,
and the extraction too.
it's the implants that are more important. Well, the alternative.
There's bone loss there, so I don't know that that's a candidate for an implant.
The issue is, how do you deal with implants in the jaw? There's not really very good studies. The studies that have been done, small studies, show that bisphosphonates actually help implants heal and take. I mean, there's studies like that. If you're afraid of all these drugs, there's something called Evista, which has no effect, I don't think, on osteonecrosis
At
of
this
the jaw.
point, since I've taken Prolia and it's close to 6 months now from the first shot, my concern is the osteonecrosis of the jaw, considering the other things I've taken.
Well,
too.
you can ask about Evista. That's a derivative of estrogen.
But if I have to have dental work done,
Doesn't matter. Has no.
my
there's-
jaw won't crumble on me?
There's no. It's a complex question, and the dentists are somewhat ignorant about some of this stuff.
They are. They can read what I can read online, hopefully they can read more in depth.
I think dentists tell the patients some bad things, so it's unfortunate. Yes?
You said earlier that if a person has lung cancer and they decide to do nothing to get into the bones, how do you know when it gets into the bones?
Well, you can have, how do you know if you have bone metastases? How do you know? Pain.
Okay.
Pain.
If you have lung cancer, there's no pain.
No, there's no lung cancer from the lung cancer, but if it goes in the bone,
Yeah.
you tend to
Okay,
have
so
pain.
if you have pain, then you know.
And then if the doctor is following you carefully, they do blood tests, and certain blood tests can go up, at least an annual blood test. But if you've gone years without any recurrence of lung cancer, then the odds are pretty good.
Doctor, what would you recommend and say the highest concentration of calcium and estrogens are found in the natural food?
Well, what are the levels of calcium in natural food? That's called milk, yogurt, and cheese. So 8 ounces of milk is 300 milligrams of calcium. 8 ounces of yogurt is 300 milligrams. Cheese is somewhat less, but people don't eat enough cheese to get enough calcium. Natural estrogen in foods, I think, is nonsense. I mean, ineffective.
So, as far as calcium supplements, I heard you shouldn't take them because they cause all sorts of other problems. Is that not, I mean, what's the latest? With
Calcium
RGs?
supplements are poison, the question, are they poison? If you take very large amounts of calcium, you can get kidney stones, possibly the arteries. But if you take a nutritionally appropriate amount, 800 to 1,000 milligrams a day, there's no evidence. That's fake news. Again.
Is that liquid calcium is better for the body than the?
No, is liquid calcium better?
Soluble calcium.
No.
Do you prefer calcium citrate or carbonate?
Either one is fine. Citrate, if you have no acid in the stomach, citrate is absorbed, but calcium carbonate is not as well absorbed. But if you have normal acid, calcium carbonate is absorbed. Tums is my favorite calcium. I don't like to swallow pills, I chew it. That's calcium carbonate.
What do you think about adding magnesium and K2 to calcium liquid form?
What about magnesium and K2? If you eat a normal diet, you probably don't have to add those things, but if you don't, you can add magnesium. Almonds are a great source of magnesium.
I'm allergic to almond, I have lactose intolerance,
So you could take a magnesium supplement and K2, but the evidence is kind of wishy-washy.
And what about this mineral that is popular, starts with an S, and it.
Strontium.
Yes, and it affects the DEXA scan, it looks good, and it doesn't good for you.
Well, in Europe, my friends published papers saying it helps. I treated 5 patients. They had to get it through the mail
Yeah, it's not
from
good.
Europe, and it didn't do anything to the bone density, and I don't think it's appropriate. Strontium, putting high levels of strontium in your bone is not natural.
Doesn't make sense to me.
No, I wouldn't do
But
it.
I know people that are on it, and they have got good results from the DEXA scan.
But that's a false positive.
Yes, thank you for saying that.
False positive.
Yes.
That's proven.
Right.
So how we can avoid the calcium deposit for the people that they always
What's the question?
the calcium deposit, how we can avoid it not to get, when we get calcium and it get deposited in a.
Well, calcium, how do you avoid calcium deposits in the arteries? Ask a cardiologist. I mean, it's,
No, not artery, or
which deposit?
everywhere. They say,
Well, arthritis leads to calcium around the joints.
oh,
So that's an arthritic problem. It's not because you're taking calcium. It's because it's a reaction to the inflammation
because they
from
told me
arthritis.
if I get the liquid, it's not gonna deposit, but if I get the pills, is
I-
it fake news again?
Liquid calcium is good for you. I don't know any evidence for that. They have to show you the evidence. Just saying it doesn't mean much. Yes?
If one is vegan and avoids all dairy, if one is vegan and has no dairy at all, is that advisable? Is there a danger to that?
Is it safe to be a vegan and have absolutely no dairy? Well, if you eat 5 pounds of leafy green vegetables a day, it's okay. But otherwise, it's not very healthy.
So really, it's really then personal preference, if you want to be a purist about the diet.
If you don't want to take dairy products because you don't tolerate them, you just take a pill. You can take liquid, but I don't know that it's any better than solid.
What do you recommend, or what would you recommend, as opposed to taking the Endocrine, the Fosamax, for weekly for 5 years, as opposed to the reclass? Is one outweighs the other, or does it depend on the patient?
Well, the question is, should you take once a week Fosamax or alendronate or reclass? The patient can decide. Do you want to take 1 pill a week or have 1 infusion?
They have the same effect?
Not identical, but they both prevent bone loss. There might be a slight increase in bone density, a little more with the weekly alendronate, but I don't know. It depends where you are on the osteoporosis scale, or if you have mild, I don't think it matters which one you take.
So you recommend if somebody is osteoporosis, take the Fosamax?
Do I recommend someone with osteoporosis to take Fosamax? Some people, yes, if it's mild and they don't have a stomach problem to begin with. It's generic, cheaper.
Fosamax is very bad side effect, very bad.
What's that?
Fosamax is very bad drug, really. It have a lot of side effects.
For a few people, side effects from Fosamax, the vast majority that I've treated have no side effects, 0. But you can, when you talk to one person that has had bad side effects, oh, it's a terrible drug. Any drug is terrible in a given person. So if you look at hundreds of people, it's not a big problem.
Repeat the one you're recommending, because we couldn't hear you back.
The one, what am I recommending?
What you just recommended a second ago?
You mean Fosamax?
Yes, thank you.
I said if people have mild osteoporosis, Fosamax is fine. But I talk to them and I say, you can take this, this, or this. What do you think you'd like to do? I think the patient can help decide what they want to take because we have so many different drugs. You want to take a pill once a month, you could take Actonel. But if you take Fosamax for 5 years or even 3 years, you can stop it, and for 2 or 3 or 4 years you're protected. So there's advantages, you know, they're different. Each one is a little different.
The same as the replacement of some of those, like a Bandronate again, for example, there is a replacement by 1 shot or 1 pill 6 months.
What do you mean?
That replaces instead of once a month, you can only take it once.
Well, I mean, there's Prolia, which we can talk about, which is every 6 months. It's totally different medicine and more expensive. So it's totally different. It's an antibody which stays in your blood for 6 months. It goes up and then it's coming down. And the problem with Prolia, it's great, but when you stop it, you immediately start losing bone if you don't take something else. And that's what wasn't well understood until more recently. So it's so effective, it's like it paralyzes the bone cells, but when it's gone, they're ready to chew stuff again.
Can you switch from a Prolia to one of the bisphosphonates?
Yeah, you can switch. Can you switch from Prolia to bisphosphonate? Yeah. Yes?
Have you ever had anyone go from osteoporosis to osteopenia?
Yes, we have anabolic drugs, Forteo. I think, let's keep going here. Well, I think we'll get to that in a minute. This seems to go backwards. I try to go forwards. Where did that go? Where I gotta catch up with. This is going.
Backwards.
I lost track of which one to push. Okay, here we go. I mentioned Evista or Riloxifene. That reduces breast cancer risk, and it also is a mild drug. It's not as strong as the others, but they can get hot flashes and a slight risk of blood clots. I find testosterone replacement in men, not with prostate cancer, but who have a low testosterone, to be very effective in treating osteoporosis. And then here we go with the Prolia is a shot given every 6 months. Forteo is a daily injection for 2 years. And there's a new one called Tymlos, Tymlos. Similar, but not exactly the same. So Forteo and Tymlos make new bone. All the other drugs strengthen the bone, but don't make new bone. So in people with the worst osteoporosis, Forteo or Tymlos should be given first, followed by the other drug, one of the other drugs. So we have a large number of drugs that are possible. Yes? Exgiva is, I think it's Zometa or reclassed or something, I think. It's a shot. It's related to Zometa. Zometa, I'm just thinking Exgiva, these names, it's one of the other drugs in a higher dose for metastases.
Could you repeat, I'm sorry, could you repeat the difference between the Prolia and when it goes to the bones and the Forteo?
Prolia is the most powerful way to stop breakdown of bone. And it results in a remarkable increased mineralization of bone without new bone, but just more mineral. Reduces fractures, etc. Forteo makes new bone for 2 years. In rats, it causes cancer in the bone, but not in humans. That's also fake news. But the FDA, because of the rats, said can't use it for more than 2 years. It's also very expensive.
So if I had not only all this cancer drugs and stuff, but I also in the past had, prednisone, one of corticosteroids for several months, and I know I have osteoporosis and it's up there. Am I better off with something like a Prolia or something like a Forteo?
Well, the use of the question is, what's better, Fortea or Prolia? Depends on the individual patient. Someone that's had radiation therapy, I don't know, shouldn't take Fortea.
Right, that's what I was
The
talking about.
FDA says don't take it because of that rat bone cancer, and rarely radiation can cause bone cancer. You're trying to cure something, but it can cause bone cancer. It's so rare. I have never seen a patient like that, but it's, you know, it's rare. So Forteo is not indicated if you've had radiation.
If somebody use Prolia, for how long we have to continue?
How long should you take Prolia? Well, it depends on what your bone density is. If it's very low, 10 years would be a reasonable amount.
And you're gonna be replaced after 10 years?
You increase the mineral, and then when you stop it, you take something else, because you're gonna lose it. You can't just stop and do nothing else.
For radio necrosis, do any of these drugs help?
Forteo may help osteonecrosis. Radionecrosis. It might help, but I don't think there's many studies. Osteonecrosis, well, that's in the bone. I mean, osteonecrosis can be caused by radiation, and it can be caused by infections, steroids, and to a tiny extent, Prolia and bisphosphonates. The question is, if you have a lot of fat, the estrogen level could be a little higher because there's some produced in there.
Yeah.
So it's healthier to not be fat for a variety of reasons.
I mean, not too fat, just a little bit.
I didn't say you were fat. I said it's healthier to not be fat. Yes.
On the aromatase inhibitors, I mean, how many of your patients, I mean, how risky really are they for osteoporosis?
Well, they're very risky if you don't know your bone density and you don't do something about it.
So
I mean, over time, it's not in 3 months or 6 months.
like most of your patients that have been on see the osteoporosis.
They're taking most patients on with a somewhat low density, not even osteoporosis, on the aromatase inhibitors are taking something like Fosmax or something else to protect their bones. As age, well, I mean, most of the people taking it are older, you know, over 50. But the bone density test helps you.
So start there and then you can make that.
Yeah, if you don't have a bone density test, you're ignorant about your bones. Yeah.
I want to ask for myself. I have a minus 2.2. So after chemo and radiation, okay, but except vitamin D3 and calcium and walking, what preventive steps can I take?
Fosamax or any Actonel, any of those drugs.
A doctor will prescribe this at this stage?
Why not? Yes.
Okay.
More people have fractures with osteopenia than they do with osteoporosis.
Really?
Yeah.
You said that before.
That's proven. That's proven.
Okay, thank you.
I'm told I'm not here to solicit patients.
If it's okay with you, we can put your name, phone number,
Yeah, I
and
mean,
email on
you
it.
can, yeah, yes. But I thought I answered all the questions.
How about we take like 2 more questions? Would that be okay? Up to you.
Do you have one? No.
Oh, I don't have one. Give it to you guys. There's one back there.
First one, there's all discussion on drugs. Are there metabolic
I didn't hear.
metabolic ways to stimulate better bone health?
What do you mean, is there
Like,
meta?
also reference a lot of animal products. I'm just wondering for plant-based diet,
Is there any food that makes your bones healthier?
lifestyle.
I'm not aware, you know, you can read anything you want on the internet, but I'm not aware of scientific studies that say if you eat this or you eat that. If you drink too much, smoke too much, take steroids, we know
And fast
how
food.
bad that is.
What about fast food?
Fast food,
No, I know you.
I worry about my arteries from fast food.
Right.
One quick follow-up is just, are there any benchmarks for improvement of bone health? As far as like time period, like I'm at maybe 2.3, so I'm just wondering, is there?
The benchmark is a bone density test.
Like are there, okay.
That's the main
Are
one.
there time periods though, and then like progress?
Every 2 years is generally.
Is there a genetic factor to osteoporosis?
Tremendous, I didn't get into that, but family histories of osteoporosis are very common in particularly women with osteoporosis. And that's something you can't, you know, that's why getting a bone density test at 50 when you stop menstruating, even if you've never had a fracture, is useful because you don't know, unless you have a positive family history, you don't know what your bone density is.
Any last
Would
question?
treatment for osteoporosis or osteopenia vary if the patient was a heart patient with AFib?
Would the treatment of osteoporosis matter if you have atrial fibrillation? No, I don't think so.
No extra concerns. Thank you.
I want to have you switch back a little bit this way. Are you available to stay after for a moment?
Yeah, I can stay a little.
Okay, so look there. We're not going to take any more questions right now. Dr. Singer is going to stay for a moment. Please don't get up yet. I have a couple more announcements, but more than anything, can we please give a big round of applause? I think that is the end of our video component of the day. Please